So we are talking about the coagulopathy that's been found in COVID-19, and this was kind of a crowdsourced talk, just so we could turn it around very quickly. So I asked Dr. Cruz, Malatek, and Thornton to look up a couple papers for us that they'll review. And then we've been talking, we have a lot of COVID on the mind. So thinking about that we still have to learn the rest of medicine, I'm going to try to tie in some things that I think are related, but just so also we're on the same page in terms of thrombosis and risk in patients pre-COVID. So we're going to review some of that evidence, and then we're going to get into what the observations are currently with COVID. And then later, Dr. Montero will talk about Georgetown's plan, and then we'll hopefully have plenty of time for some discussion because we got some people from the hematology department joining us as well. One of the things that I saw that I thought was interesting was this article, and it's not a peer-reviewed, it's in the Los Angeles Times, but it was a case of actually 5 cases at Mount Sinai in New York where the team there had really sick patients, like a lot of people have, and they said, you know, we couldn't get the imaging we wanted to because it wasn't safe to transport patients, but we really just thought it was screaming blood clots. And so what they decided to do in these 5 patients is give TPA. And, you know, the quote here is like, what do we have to lose? You know, if anyone tuned into other talks, and we've talked about, you know, when you kind of use things kind of in an off-label manner, in an uncontrolled manner, or, you know, what do you really learn from it? I think that's something we can kind of get from this talk to think about what are we going to try to learn. But at the same time, hopefully everybody knows TPA has some major adverse effects. And if you've ever had a case that had proven saddle PE, you talked about it for a long time before you gave TPA. I'm not talking about, you know, a sudden PEA arrest or something like that. I'm talking about where you had diagnosed clot and you still thought about it, and actually many times probably still didn't give it. So what do we have to lose? I think there's potentially a lot. Just as an aside, these 5 cases, 2 of them died and 3 of them remained intubated despite the TPA. So it's hard to say that anything really changed because of it. And you don't know because it wasn't in a controlled setting. So again, we're going to talk first about what we know about thrombosis or VTE. And so, you know, we're in a place now where we almost universally give prophylaxis for VTE, but just so you know, not the entire world is there, and we weren't there before. So there were a couple of seminal papers, this one from 1999, looking at 40 milligrams of Lovenox, this one from 2004, looking at dalteparin, which is fragment or equivalent, prophylactic dosing, and this one in 2006. And they all showed a benefit, but just so you know what the design of these studies were, it was looking at serial Doppler measurements. And so it didn't matter if you had symptoms or not, they would check serially and find if you had a clot. And so they did find reductions, but a large number of these patients had no symptoms and in normal practice wouldn't have probably warranted ultrasounds. And so since those seminal papers came out, the Joint Commission has had guidelines recommending at least, not universal, but at least assessment for adults coming to the hospital for prophylaxis. And this is a study that came out after that, reviewing the time before those recommendations came out and after. And on the left here, you can see that really the number of patients inpatient that got prophylaxis went up around 2007 and 2008. And they were nearly to 90% in both females and males by the end of this period. But what was interesting, when they looked at the rate of clots, they actually found no difference in the hospital over this 5-year span, and also in what they call hospital-related clots, which is not just the clots that happen in the hospital that happen up to 90 days after, because in previous work, it had been found that your risk of clot from a hospitalization probably extends out to about 90 days, even after you're discharged. So when they looked at those events, you know, 50% of them were unrelated to the hospitalization, so these were just people in the community. So this wouldn't have had any impact on that. But when they looked specifically at the in-hospital and hospital-related events, and those did not change significantly, they tried to figure out why. And a lot of it was because the hospital duration is not necessarily very long. So the median stay in this study was 3 days. And so if the risk extends out to 90 days, you're not getting covered. And then when they looked at it specifically when the clots happened, the median was about 20 days after discharge that the hospital-related events happen. So their conclusion at this time was, what we're doing is not actually making a big impact, and maybe a better strategy would be to do something in the highest risk patients for a longer period of time. Interestingly, other people had looked at those seminal papers and excluded the asymptomatic cases because they didn't think this represented real practice. And also they thought that the patient population then versus now was different. So they wanted to know if it actually made an impact. And so those same 3 papers here that we looked at the very beginning that all showed a benefit, when you exclude the asymptomatic, actually don't combine show any benefit. So I think that's interesting. So again, and some maybe more evidence that our prophylaxis isn't maybe doing as much as what we think it is. If you look at, here's another meta-analysis that looked at more papers. This paper, they still didn't find a difference in overall clotting rate, but then they looked at if pulmonary embolism specifically was affected. And so they did find a benefit in preventing pulmonary embolism, and not necessarily all clots, including DVT, but specifically for pulmonary embolism. And they had a risk ratio of 0.4. But when you look at the actual event rates, it went from 0.49 to 0.2% for an absolute risk reduction of 0.3 essentially. So that equates to a number needed to treat of 345, or 345 people need to be on multiple to single day injections to prevent 1 PE. And then they comment also that the bleeding risk seemed low, but actually none of the studies really routinely assess this. So even if it was about half the rate of what they were seeing, half of people that got prophylaxis were bleeding, that was probably underrepresented because it actually wasn't followed in many of the studies. So that's kind of general VT, but what about in the critically ill, which maybe is a little bit more pertinent to our talk today? Well, the thing is, we actually don't really know. It's not really well been looked at. There's retrospective stuff, but you can imagine ICU populations are very heterogeneous from country to country, from community to tertiary. And so the best estimates we have seem to be that in critically ill, the PEs has been seen as up to 30%, 27% of cases, which I think is, again, post-mortem, so these are the ones that didn't do well. But that's kind of the best evidence there is for PE in the critically ill. And then in DVT, the range is all over the map, less than 10% to 100%, which we know for sure it can't be 100%. I hope it's not 100%. But it just all depends on the definition. So the answer is we really don't know. Looking at what some experts think, it's probably in the 10 to 15% range, because there has been some studies that had control groups, and in the control groups it was around that range. But you can see that we really don't necessarily know. So to compare what we're going to see today to COVID, to say, is this worse than what our normal critically ill population is, there's really no way to say. But what about, why do people critically ill get clots maybe more than the normal population? Well, there's many different factors, but we already know this, that severe sepsis is associated with DIC. I think we know this. But there's other things that are associated with it. And I think the key player here is tissue factor. This is obviously way more complex than we need to get into. But tissue factor is going to be a recurring theme here. But basically, the immune system is known when activated to activate coagulation. Getting more kind of granular, you guys can remember this probably at some point in your careers learning it. And so here's your tissue factor again, and just tissue factor is released by immune system to infection, but it's also released because of trauma. It's also released because of something like pancreatitis, right? So just general inflammation. And specifically on the endothelial level, where maybe a lot of this damage is happening, activated protein C is kind of this target that people were thinking, what if we intervened here? Because at some point, mortality in the critically ill was thought to be driven a lot by microthrombi in addition to gross thrombosis. So the thought was that the inflammatory cascade is really activated. You're getting multi-organ injury because of these microthrombi. So those of us can remember learning about active protein C. This was actually a pretty hot thing at one point. And so if you think that those graphs are complicated, if you look at it even more in detail of how everything interacts, it's way more complicated. And this is probably still a simplification. But the point is that the complement or part of the innate immune system is key into the coagulation cascade and one of the key factors of releasing tissue factor. And so this is nothing new to COVID. This is known that inflammation, its endpoint is coagulation, and actually fibrinolysis is one big part of it. Okay, and I guess if we were to talk to, for example, Dr. Broom, she'd probably say this is still an oversimplification. So the theory was sound that maybe if we intervene and stop coagulation because it's driven by inflammation, by using activated protein C, maybe we'll have an impact. And it turns out this is an example where early studies were very promising. So observational, retrospective stuff was very, very promising, had mortality benefits. And so it led to this being taught as something, maybe the new intervention that's going to make a big impact. And it turns out when they did the actual randomized control trials, and then this is a meta-analysis of multiple of them, it had absolutely no effect on mortality, no effect on so in-hospital mortality and all-cause mortality, and it had a risk of bleeding that was higher than not giving it. So it turns out, what was once looked at promising, if you just looked at observational or retrospective data, when you actually did the randomized control trial, had really no benefit and had a significant harm. And actually, very shortly after this, the pharmaceutical company that makes this just stopped making it entirely. So it's not even an option anymore. So what about thrombosis in COVID? So we're going to move on to what the evidence we know here. So, in the time that I asked the other speakers to talk, multiple papers have come out. So there's no way we can do this exhaustively, but they're going to pick some key ones that I think are illustrative of what we know and maybe what we don't know. And then, people are putting out how is it specifically that SARS-CoV-2 factors into what we already know. And you can see here it's kind of the same thing where you get a cytokine storm, tissue factor is involved, and you've got coagulation cascade going to fibrinolysis. This has also been looked at previously in SARS-CoV-1, and here's the model in SARS-CoV-2 at the alveolar level. And so it's not, again, it's not new that inflammation in the alveolar level would be associated with some microvascular thrombi. And then, as we transition over, just so that we are all on the same page in the kind of order of how things were described, here's one paper that was observational from China that I think the big takeaway home was when they looked at people that survived and didn't survive, the non-survivors had elevated Ddimers, and it was different than the survivors. So here's maybe where one of the first signals of, hey, there's something different going on in these non-survivors. But just as a reminder, since we know fibrinolysis was a endpoint of inflammation, this, we can say this is probably a marker of inflammation, but maybe it's something more.
Thanks, Ernest. So I was going to start by reviewing this paper that came out April 3rd in the Journal of Thrombosis and Thrombolysis. We actually looked at this on the ADMIT team 2 weeks ago. So this was a study out of China that looked to compare coagulation features between severe pneumonia that was induced by SARS-CoV-2 and pneumonias from other etiologies. And they also wanted to evaluate whether patients with elevated D-dimers could benefit from anticoagulation. Next slide. So this was a retrospective analysis, and they looked at consecutive patients that were admitted to the hospital in Wuhan. So for COVID patients, go ahead, Ernest. For COVID patients with severe pneumonia that were admitted from January 1st to February 13th, and those that were admitted with severe pneumonia, again from another etiology, any other etiology, that were admitted to the ICU between January 1st and October 1st of 2019. And when they said severe pneumonia in both of these groups, they just had to meet any one of the following criteria. So a respiratory rate greater than 30, arterial oxygen saturation less than or equal to 93% at rest, and a PaO2 over FiO2 ratio less than 300. So any one of those three criteria. Next slide. So they looked at different coagulation markers in this patient, so PT, D-dimer, and platelets. They also looked at the medications that these patients got, as well as their 28-day mortality. The medications that they focused on were anticoagulation treatment, they called it. And, you know, I was a little bit disappointed to find that this is really kind of this is the equivalent of what we would say is DVT prophylaxis in the hospital, generally speaking. So low molecular weight heparin, 40 to 60 milligrams daily for 7 days or longer, or unfractionated heparin for 7 days or longer. Next slide. So this just shows a table of comparing the COVID and the non-COVID patients with pneumonia. There were 449 in the COVID pneumonia group and 104 in the non-COVID group. Some of the things that were statistically significant and different were that the COVID patients were older, that they had, unfortunately, twice as high of a mortality at 29%. And the other potentially interesting thing is that their platelet counts were higher. Interestingly, we've been obviously following these patients and their D-dimers, but when we actually looked at the COVID, when they actually looked at the COVID versus non-COVID patients, there was not a statistically higher D-dimer in the COVID group. In fact, they trended to be potentially lower. Okay, next. So when they looked at the patients in the COVID group, those that received prophylaxis, which is 22% of them, and those that did not, there was no difference in 28-day mortality between the two groups. This was the same in the non-COVID pneumonia group. So it didn't matter as far as their 28-day mortality whether or not they got prophylaxis. However, when they actually looked and stratified by D-dimer, they did find that in the COVID group, there was a correlation with improved mortality in the patients that got prophylaxis. So if their D-dimer was greater than 6 at the upper limit of normal or higher, these patients had a statistically significant, improvement in their mortality. This did not bear out in the non-COVID group. There was no statistically significant difference between mortalities. So potentially a little bit interesting. So I guess before I say the take-home points, there are certainly some limitations in this. This is a retrospective study. They noted that there could be some selection bias. Those that got low molecular weight heparin or heparin could have other targeted symptoms or medical history that made them give those therapies. They also don't look at some of the other kind of differences between the patients. But I guess potentially my take-home point is that when we're thinking about prophylactic dosing of these, sick COVID patients, especially those that have higher D-dimers, it is likely very important that they're on DVD prophylaxis. So I think that we could say that at the very least, our COVID patients who meet these criteria should be on prophylactic anticoagulation.
So I'm going to talk next about two papers that try to answer the question about incidence of thrombosis in COVID-19 patients. So the first study that I'm going to go over is a study that came out of 3 Dutch hospitals, and they did an observation of 184 patients that were admitted to the ICU with COVID pneumonia. Notably, their patient population, the general statistics, they comment that 76% were men, but don't really comment on other healthcare problems that they may have. 13% of the patients died, 12% were discharged, and 76 were still in the ICU at the time that the study was sent for publication. Next slide. And so all of the patients that were admitted were placed on VTE prophylaxis, the low molecular weight heparin. And interestingly, halfway through the study, they increased the VTE prophylaxis dose to a high dose, so kind of our equivalent of Lovenox 40 milligrams BID instead of daily. And they only imaged patients if there were clinical signs of thrombotic complications. And what they found was a 31% incidence of thrombosis, looking at DVT, PE, MI, ischemic stroke, and other arterial thromboses. 81% of those complications were actually were PE DVT, and one was a proximal DVT, two were catheter-associated clots, so the majority were really PEs, and then there were 3 ischemic strokes noted. They found that age and coagulopathy defined by a prolonged PT and prolonged PTT were independent predictors of patients developing thrombosis complications. And it was just interesting that in the study, they make a comment that none of the patients were found to have DIC, which I think is a little bit different than some of the other data that's been presented about the potential incidence of DIC. Next slide. And so a couple of the questions that I had when I read through this study, and again, it was short, it's like 2.5 pages, so it's not a lot of information, but the DVT prophylaxis, it was standard when they came in, but the standard dose changed during that observational period. And as they started to recommend or consider higher dose DVT prophylaxis for COVID-19 patients. Imaging was only done if there were clinical symptoms, and 76% of the patients remain in the ICU time of publication, so it's hard to know if 3/4 of the study population are still in the ICU, what potential complications those patients may have, or if they're developing more thrombosis. The second study I looked at was a study out of Wuhan where they, again, retrospective or an observational study of 81 patients with severe COVID pneumonia, where they found 25% of the patients had some sort of VTE event. And the demographics of this study, 54% were female, 41% had chronic medical problems, and 43% of the patients report smoking. And in this study, all patients had labs, had physical exam, had CT and lower extremity Dopplers looking for DVT. They note that all patients were on antivirals and other supportive care, but don't go into detail of what exactly that is. All patients were defined to have severe pneumonia based on their international determination scale. And also of note, none of these patients were given DVT prophylaxis initially. It seems that in this hospital, that's not a routine practice. And the labs that were collected were PT, PTT, thrombin time, INR, fibrinogen, and Ddimer. And their outcomes, 79% were discharged, 10% died, 11% remained in the hospital. And again, 25% of these patients developed DVT. And then there's a little bit of a disconnect because in the text of the article, they say 8 of the patients that developed a thrombosis complication died. But then when you look at the tables at the end of the article, they only comment on 3 patients dying during this time frame. So I'm not entirely sure what to make of that discrepancy. And so the findings that they report at the end of the article, or their conclusions, are that patients have increased risk of DVT if they have older age, if they're more lymphopenic, prolonged PTT, and having a higher D-dimer, with the caveat that neither group, those with DVT or without DVT, had normal D-dimers. And then they make almost this leap of faith in my assessment, where they say, yeah, we know that the D-dimer can be used to help thrombus with high sensitivity and low specificity in in how we use D-dimer. But they say based on this 81 patient study, the sensitivity, specificity, and negative predictive value is pretty high when the D-dimer hits a cutoff of 3. And they even say, well, maybe that should be the cutoff to determine if these patients have clots, and then you use the D-dimer to help determine if patients are getting better with anticoagulation therapy. And so that was kind of their conclusion to their study.
Okay, so based on all of that evidence, we have a signal that thrombosis is common. There are coagulation problems in COVID. And so the big question becomes, like, what can we do about this? Like next, so should we therefore be using prophylaxis widely as we may think? Go ahead. So the last study that we're going to review for now is kind of the one that attempts to answer that question, anticoagulant treatment associated with mortality in severe coronavirus, and this is coming out of China. So the study design, it's actually the same patient cohort as what Dr. Malatak described, so consecutive patients with severe COVID-19 between the 1st of January and the 13th of February. And she already went over the definition of severe. This is a retrospective evaluation, as she said before, and it's of treatment versus non-treatment groups. But the interesting thing is, it seems that, as Dr. Thornton alluded to, prophylaxis in China is not a pretty standard thing to do in the hospital. And so in the early stages of pandemics, the majority of patients were not on anticoagulation. And then as the signal started coming out, people started using anticoagulation. And so these two different groups, the treatment versus non-treatment groups, actually largely represent differences in time as well. So the outcome was mortality. And again, as Dr. Malatek mentioned, the quote-unquote treatment group was actually prophylaxis. So the low molecular weight heparin in the doses that we use are slightly above, as well as unfractionated. And it had to be for 7 days or longer. So if they received those medications, but not for 7 days, for example, they were discharged, they were in the non-treatment group. And then I think the most interesting thing to come out of this is the subgroup analysis they did by 6-score and D-dimer level. Sorry, that would be my dogs in the background. So I wasn't familiar with the 6-score, but 6 stands for sepsis-induced coagulopathy, and this was developed as the idea was to identify an earlier phase of sepsis-associated DIC. You know, the full definition of DIC includes a drop of fibrinogen, and apparently this isn't terribly common in sepsis, or at least early sepsis. And so this was to identify people who were in an earlier stage. So the 6-score just counts 3 things: platelet count, PTINR, and their SOFA score. And you can see the stratification there. And if they had a score greater than 4, then they were, it was a dichotomy, either a low 6-score or a high 6-score, and so high was greater than 4. So the results, again, they identified 449 severe cases, and the total number of cases you can see was about 1,700, 1,800, so about 25% qualified as severe. And again, all these patients received both supportive and antiviral therapy, so this is different than our patients who it seems rarely receive antiviral therapy at this point. Of that group, 22% were in the quote heparin treatment group, meaning they received it for at least 7 days. And about the same percentage, although not overlapping, had that higher 6-score of greater than 4. If you looked at D-dimer, there was a larger group that was considered at higher risk. About 36% had greater than 6 times the upper limit of normal. So interestingly, the overall 28-day mortality rate was about 30%. And then when you stratified it by heparin users and non-users, it was essentially the same. And this is what Dr. Malatak alluded to earlier in her review. But if you look at the differences between survivors and non-survivors, age is one of them. as well as multiple of the coagulopathy indicators. So I think the most striking one would be whether or not they met the sick criteria. 13% of the survivors met that criteria, whereas 41% of non-survivors did. PT and platelet count we've already talked about, as well as Ddimer, which did have a marked difference between survivors and non-survivors, but also of note, as we mentioned before, the Ddimer was in fact elevated in survivors also. And if you stratify by 6 score on survivors versus non-survivors, if you could click, even when treated with heparin, they had a higher 28-day mortality than baseline at 40%, but if they weren't treated, it was an extremely high mortality at 64%. And if you could click again, I found it interesting to note that if they did not meet that higher score, it was not statistically significant, but it trended towards actually improved survival in the non-treatment group. So it's a little confusing about what to make of that. And if you could click one more time, if you look at kind of the similar idea, the patients who, when you stratify by Ddimer, are not seeming that sick, the difference between heparin users and heparin non-users is actually significant, and the non-users had a better survival rate. Next click. But again, if you trend towards higher Ddimer levels, it becomes statistically significant at above 6 times the upper limit of normal that people who were treated with heparin had improved mortality compared to those who don't. Next click, though, I thought it was interesting that if you kind of draw a line across that 30% mortality rate, which was the average overall, in the heparin users group, that stuck pretty close to that 30% mortality rate, except for those with a high 6 score, who was up to about 40. But in the heparin non-users, the mortality is really what varied. And so the question this raises in my mind is, there's certainly some baseline mortality of COVID that maybe is not related to anticoagulation, and maybe if we can identify those higher risk patients and treat the coagulopathy in them, it decreases maybe that extra mortality that they're having with that coagulopathy, but it doesn't, decrease it any more than the baseline level of mortality. So there's certainly other factors involved. Next. So a couple interesting things to come out of this paper that are to think about. They mentioned that, genetic risk factors vary by ethnicity for VTE, and the incidence is lowest in Asian populations. And so the study authors postulated, well, there seemed to be some signal of improvement in anticoagulation in the high-risk patients, but maybe higher doses might be needed in non-Asian populations. And then the thing that I thought was interesting, and this is just really more of a conjecture, but attempting to explain why in the low D-dimer group, the low-risk group, that they actually had worse outcomes with anticoagulation. It seems that activation of coagulation is involved in the natural immune response to pathogens, and so it contributes to compartmentalization and reducing invasion of pathogens. And so, this was a postulated reason that maybe those with lower D-dimer who were lower risk overall, maybe they had worse mortality because we were somehow interfering with the immune response. Go ahead. And so really, if you click twice again, what I got out of this paper is that the patients who really benefited from anticoagulation were the severe cases. They were the ones selected to begin with. The mild to moderate were not even included in the study. And the ones with coagulopathy. So either that 6 score greater than 4 or the D-dimer greater than 6 times the upper limit of normal. These are the patients who had an improvement. Thank you.
Next, we just have a couple of examples of what different societies or bodies are saying in light of this kind of information. So you can say the American Society of Hematology, its main recommendation is just for prophylaxis. And it's actually nothing different than what we would normally do. The JAC came out with guidelines too, specifically saying there's insufficient data to consider routine therapeutic or intermediate dose anticoagulation. But even in DIC without bleeding, you should give prophylactic anticoagulation. Anyone on chronic anticoagulation should continue to get that, but you might even consider reducing the intensity of that anticoagulation. And then you could consider risk stratifying people for extended duration prophylaxis for up to 45 days discharge. And Sarah, I don't know if you want to talk about this.
So the Brigham has been updating COVID guidelines for ICU care, and they also have been putting out their recommendations and reviewing some of the same studies that we have, and they again recommend prophylactic anticoagulation in patients unless it's otherwise contraindicated. They also said maybe, and this kind of goes to what Ernest just said from Jack, that if patients come in on anticoagulation, then maybe we consider switching them in the hospital to either low molecular weight or unfractionated heparin based on the clinical scenario while they're in the hospital. And they felt like there's not enough data at this time to give true therapeutic anticoagulation empirically to these patients unless they have a documented DVT or PE. And they said the same thing about TPA, that we don't have enough data to make any recommendations for that at this time.
There was a webinar from the ISTH, and I think the summary from the two experts were that stick to the basics, remind yourself what you know, stick to safe things, and if you want to do something, put them in trials, and we have to come together as a community to investigate this in more detail.
So kind of summarizing everything that we tried to talk about this hour, we all know that inflammation is a big driver of coagulation and coagulopathy. The baseline incidence of thrombosis specifically in the ICU is not really well established, and these are the patients we're talking about with severe COVID. You know, we've all gotten very excited about tracking the D-dimers in COVID pneumonia, but it's actually high in any form of severe pneumonia, so it's not entirely clear what we should be doing with this information. And so while it's prognostic, you know, we're not at the point where we're going to treat a number. The question came up like, oh, if they have a high enough D-dimer, should we just go ahead and anticoagulate them? And that's not recommended at this time. The Chinese studies that are coming out, it should be remembered that they're quite different than our studies because they essentially have no program for baseline VTE prophylaxis at baseline, and so their populations and their treatments are different. As Dr. Fisher just showed, multiple bodies are recommending against empiric therapeutic anticoagulation except in the context of a clinical trial, and it's because we don't have the data. You know, it's much better than to go, you know, more than to go off a theory and try out what we think might help. Let's actually measure whether it helps and do a clinical trial so that we do have that data for the future.
All right, and then we're going to let Dr. Montero tell us a little bit about what's going to be happening at Georgetown.
Go full screen here. I don't need to impress upon you the relevance to our service. This question, this is what my census looked like yesterday. You may know this patient that we took care of over in C63. I'll just point out that I got this pop-up saying the D-dimer on the 17th was ungraphable. I've never seen that before for a level. But as it turns out, it was probably the day that this occurred. He had, you know, 5-lobe segmental, subsegmental PE diagnosed, and he'd been refusing his heparin about half the time along the way. It's a difficult patient for a number of reasons, but you know, what I want to briefly tell you guys about is this RCT that we have a chance to be involved in. The collaborators include Tim Plant out at University of Vermont and Mary Cushman, who I understand are, you know, well, I know Dr. Cushman is a well-established, big NIH-funded investigator, so this has a good chance of getting some NIH funding eventually. But essentially, it's an RCT. We've been talking about all the baseline evidence, which I'm not going to go over, you know, because you've already heard it in detail. about why this is relevant. Here's the stuff about the Ddimer that you guys went over in great detail, and the mortality risk associated with that high level of Ddimer you've touched on. This is a slide about this, but there's animal studies and in vitro stuff suggesting that there might be a benefit to anticoagulation. So outside of just clinical data, there is some, I guess, biologic rationale for why this might be helpful for patients with COVID. But this is a slide we might want to dwell on. I mean, Dr. Kessler, I don't know if he's on the call or not, but I think he's making a very cogent argument that we need good evidence on this. Everything we presented so far on this call was either retrospective, non-randomized, expert opinion based on this data, but really no RCTs have been done to actually answer this question. And at the same time, we've got protocols, including here, I know the ICU group is talking right now about D-dimer, low, intermediate, high, and empiric anticoagulation in the high group in anybody in the ICU. So guidelines are coming out on this incomplete evidence, and as Ernest just showed you, that last slide is a call for good evidence, get patients into trials to try and actually answer this pretty urgent question as I see it. You guys just showed this data. So here's what it looks like, the RCT. It would be a pragmatic one-to-one randomized study. The intervention arm would get therapeutic anticoagulation, and standard of care would be prophylactic doses for everybody. And the idea being, can we introduce heparin early in the intervention arm and potentially impact on the inflammation and downstream sequelae that you guys described earlier in the background literature. The main outcome would be a composite of ICU admit, non-invasive ventilation, or mechanical ventilation and or death at 28 days. It's a pretty clean study design. Here's what the arm that would be therapeutic would look like. So low molecular unfractionated heparin, you can see there the dosing with a plan for 2 weeks of administration or until ICU admit or hospital discharge or ventilation of some sort. This is kind of what we're already doing for many of our patients. Standard care is getting prophylactic dose anticoagulation. Here are the agents that would be included. And just quickly, it's hard to see this one, but these are the criteria to get into the study. The inclusions are threefold. Lab diagnosis of COVID. Severe disease is defined as just being admitted to the hospital. And then 1 D-dimer value, 2 times the upper limit of normal within 3 days of being admitted to the hospital. That's it for inclusion criteria. There's a bunch of exclusion criteria. I'm not going to go into all of them. Morbid obesity, severe thrombocytopenia, bleeding issues. But I'll point out that our patient that I presented at the beginning of the slide deck was on dialysis. That's not one of the contraindications. So he would have been eligible for this trial, actually. Not that he would have been a patient that would have agreed to it. But I mentioned the outcomes. Secondary outcomes include what you're seeing here: major bleeding, how long the admission runs, the need for transfusion, and any clotting events. Just general consideration about if we collaborate for this trial, the consent process, is going to be, we're going to attempt to do it remotely as much as we can. And all study activities we would try to coordinate very closely with routine care, essentially. That's what the slide is speaking to. Not to minimize any study-related stuff that would occur that wouldn't already be occurring for routine care. And I'm leaving out slides here about, some sites are going to get blood specimens at admission and at some time point after randomization. Stuff like that will be done as part of routine blood draws, not additional study-only type blood draws. And again, the consent process would be ideally done remotely so that we don't increase the number of times folks have to go into the room related to this study. But this just goes back to why is it important? There's suboptimal data trying to guide us right now, and it's a call to try and get people into an RCT, which might answer this definitively with good data.
So I think we have a few members from the hematology department on the call, and so if anyone of them would like to add anything. In the meantime, if they're getting ready, I see a question about when should we send people for a CAT scan. So I think that the example that we've had, there's been a couple of PEs. I think it sounds like there were some symptoms that could have made your suspicion go up. So in this case, a clinical change where the person, I think, became more hypoxic and hypotensive suddenly. So I think we're trying to kind of say it's not the D-dimer that should make you send somebody. It should be the D-dimer is high and you have some clinical suspicion and the patient has some symptoms that would be consistent with clot, then you should send somebody. I don't know if anyone else wants to add to that.
You know, Ernest, for that patient that I described to you, it's typical patient where they're on dialysis, so they intermittently, and they're on amantadine, so they get hypotension is sort of a common event for that patient almost daily. Our nocturnist, I don't know if Duncan's on the call, but Duncan got a call for hypotension early one morning in his course and triggered the CTA of the chest, and we saw, 5-lobe PE with right heart strain. Guy looking pretty good at the bedside, no shortness of breath, nothing else. It just speaks to it's challenging, but we did note the D-dimer. Both Marissa and I saw that D-dimer that was, we thought almost like an outlier when it was so high. But we didn't know that there was any, we didn't know of any reaction to that, just elevated D-dimer that would be evidence-based, so we didn't do anything. But, it makes me wonder, relying only on symptoms may not be adequate is what I'm thinking. But it's just that's just, speculation.
Yeah, I mean, I don't think I've seen a D-dimer that high. And I think even before this, I've had a couple of cases where someone had large PE and then they were just sitting there. So it is sometimes hard, but I think.
Yeah, we were ascribing the hypotension to something else, right? Oh yeah, he's on amantadine, and I'm sure it's dialysis related. And Duncan challenged that and said, yeah, I know he's on amantadine, but I got the CAT scan anyways. And here's what we found, which was a great call by him.
Yeah, but I mean, I guess it wasn't during dialysis, but I think the issue is, I mean, I guess we can't go to the extreme that just the D-dimer is what the reason to send somebody to a scan is. I think we'd want to have something.
Yeah, I would agree with that for sure.
I had a patient who had a D-dimer with COVID who was 14 and she was already on anticoagulation, and I kind of looked at her legs and scanned her legs, and they were fine. Not officially scanned her legs. And then she was breathing fine. She's actually recovering. So I watched her for a couple more days, but she didn't have a PE. I checked on her when she was at home. She's still alive. So I think D-dimer I think that's not a really good test to make your decision about whether or not. I think it's clinical plus maybe an elevated D-dimer. And so I guess the hypotension was the key in that patient.
I think we're hearing about cases of some cutaneous thrombi that looks like maybe vasculitis. To answer one of the questions, and I think there was a dermatologist that described pernio in the toes, which I think is probably a similar phenomenon. But I don't know. We didn't look into the studies on that. And then just like Dr. Malatek, the lesser Dr. Malatek, I had a case where the D-dimer was high and our patient was getting worse, and we did send him for, it wasn't 20,000 high, but it was something like 4,000. Got 4 extremity Dopplers, got CT, and it was all negative. But the COVID findings in the lung were actually much worse on the CT.
Yeah, and Ernest, this is Virginia. I think, Duncan had made a good point to us that we should feel, we're trying to avoid tests when possible, but we should certainly feel empowered to do that when we're concerned. I had another patient that came in and his D-dimer was 20, and he didn't have any significant change in his breathing, although it was bad enough that he came in with the symptoms. And we ended up diagnosing a PE in him as well. So it can be pretty hazy, but it seems like we have to kind of walk the fine line between, avoiding unnecessary tests, but feeling empowered to do them when we're concerned.
Yeah, and by all means, do a test before you. So I think we're not trying to discourage a test. We're discouraging empiric anticoagulation. So you want to.
Yeah, Ernest, can I echo that? Because I spoke with Dr. Cooper initially when we first started getting COVID patients, and they were really reluctant to do the CAT scans on them. and so I've sort of been hesitant, like Virginia described, but now with our census the way it is, I think they're probably much more, comfortable, and they've worked out processes to keep it safe down in radiology. And so I think the environment is different, and my attitude of like, oh, I don't want to do unnecessary testing, probably can be scaled back a little bit.
There was this correspondence that came out in New England Journal, so it's not a trial, it's just an observation that was reported about antiphospholipids being elevated, as someone had that question. And it looked like, first off, they didn't give any titers, and a lot of the things that they were finding were IgA, although there's some IgG. And then, so if you look at, I guess, the criteria for antiphospholipid, it doesn't have IgA anywhere in there. And the titer is actually very important. It has to be 99th percentile or more. So I don't think right now this is too useful or much of a marker as far as I can tell. And I think many people would tell us, Dr. Welton included, that just a lot of acute illness can have transient antiphospholipid elevations or positivity.
I'll just say that I have nothing to really offer that's going to help here. Maybe only hurt. Am I unmuted? Yeah.
Yes.
I'll just tell you that, over the weekend or this last 4 days, it's hard because we're on like this 4-day schedule. I don't even know what date is today. I finally have a day off, but it's hard to get some of these people to CT scan. Like, we see them with such high dead space. We're measuring this end tidal CO2. When it's widely discrepant from the arterial CO2, it can be a clue of dead space increase. Their D-dimers are, double digits or off the chart, or, even unreadable, as your case was. And, I tried to get someone down to CT scan for 3 consecutive days, but paralyzing them on one pressor, nurses' concerns, had to, escort the patient to the elevator finally, and send them down. And the patient didn't have a CT, a PE, as it turns out. But I don't know. It's just, it's hard to watch someone with a very high D-dimer, the high rate of mortality we have on the ventilator, looking for and seeing some indirect evidence based on ultrasound, not finding a clot in the legs, and withholding anticoagulation at therapeutic level. They don't meet any of the obvious indications, pre-existing AFib or history of clots or clotting off their filters. It's sometimes hard to withhold that anticoagulation. I honestly have no answer, just more questions on what to do in that case. I love the idea of eventually having a trial that might answer this, but in the immediate time frame, it's hard to watch mortality happen at such a high rate when PE and DVT seems to be playing some role in patient decline.
I think maybe someone from hematology could comment, because I think it's interesting that, how much of this is a DIC, is it not DIC? And I think Dr. Thornton had a paper where none of the cases were DIC, and then some of the other ones have, almost all of them meet the criteria for DIC. So I think in that context, and actually in the hematology talk 2 days ago, they were kind of talking about how even if there is thrombosis, it's unclear that anticoagulation is the treatment, just like as it wouldn't be for DIC. So even if it's happening, we don't necessarily know if it's going to help to give like really sick people anticoagulation. So I don't know if any of the hematology group wants to expound on what they talked about on Monday.
Hi, it's Catherine Brew from Hematology. Can you guys hear me?
Yes.
So I think that, from all of the information that we're getting and that we're reading, this is probably not your typical consumptive coagulopathy like DIC. It really looks like it's a definite thrombotic type of coagulopathy that's certainly, I think, being driven by a lot of the inflammation and endothelial damage that's going on. Whether anticoagulation, as we normally think of it, is going to be enough to stop this process, that's probably being driven not only by coagulation proteins, but also by platelet activation endothelial damage, monocytes, macrophages, neutrophils, etc., remains to be seen. And I think the study is really excellent to try and help us. And I agree with Dr. Vinayak, it's a little hard to, watch somebody be critically ill and not anticoagulate them. But, hopefully as we continue to make additional observations and learn more about these patients, we'll have a better way or a more directed way to approach this coagulopathy, which I think is contributing definitely to morbidity and mortality. I think it's just very complex, and I don't know that addressing it with one form of therapy, i.e. heparin, is really going to be the answer, but we're trying to understand and learn.
All right, guys, we're at the hour, and I think we got through most of the questions. Just one so that everyone hears it. We haven't seen much from New York City, but I think the group that is putting together the actual study that we're going to be a part of had talked to some groups in New York City, and there was some preliminary data that it still is a high signal of clots, but so that hasn't been published as far as I know. Anyway, thank you to everybody for participating, Dr. Thornton, Dr. Malatak, and Dr. Cruz for very quickly turning this around. And we will have this up shortly if anyone missed parts of it.